All right, it's my pleasure to introduce Chris Bowlus, our next speaker. He's Professor-in-Chief of Gastroenterology and Hepatology at the University of California in Davis. And he's also a member of the advisory board for the PSC Partner Scientific and Medical Committee. So he's going to be talking to us about new treatments in PSC.
Okay. Thank you. Is someone going to help me with this? Excuse me while I try to find my slides here. What's that? Oh, there they are. Okay. Well, good afternoon, everyone, and thank you for inviting me to come speak today. I know you just heard a lot about transplantation and the difficulties with it. Fortunately, many of you will never need that. And ultimately, our goal is to find treatments so that nobody needs it for PSC any longer. So I do want to put, Dr. Mulligan out of business. So 5 years ago, we had this conference in Sacramento, and we had a similar talk on, new horizons for the treatment of PSC. And I think we've made some progress since then, but I think we still have some major barriers to get over to really getting a therapy approved for PSC. And it's become very clear in the last couple of years that there are these barriers for us to go through the drug approval process. And I think one of the take-home messages I would like you all to take from this meeting has to do with the need to understand the natural history of PSC and what it's going to take to show that a drug is effective in these clinical trials. And despite those difficulties, there's actually, though, a lot of activity here in the field of treatment development or drug development for PSC. And so, in a way, we've kind of come out of the desert and into the woods. So the reason for that analogy is in the past, we sort of had this desert of possible treatments for PSC. We had ursodiol, our one lone sort of palm tree in the desert, and there wasn't a lot of other treatments available to even test. And now we're kind of in the woods. We have all these different things to think about, vancomycin, obeticholic acid, NOR-URSO, etc. But it's not clear that we have a path of how to get out of the woods now. We're kind of lost in this maze. And so what I want to go over is sort of what the process, what it's going to take to get to a drug that we know is effective and safe for PSC. And so the first thing to think about is what is the natural history of PSC, because what we want to do with any therapy is alter, either slow or halt the progression of this disease. And the natural history of PSC is somewhat complicated. Is my pointer not working? There it is. No? How about this? That doesn't work either. Okay. So basically, we can't diagnose PSC until it's well established, right? So we can't diagnose it until there's an abnormal cholangiogram, and there's already a degree of biliary fibrosis present. And then it progresses over time, typically to portal hypertension, and then complications such as variceal bleeding and the need for liver transplantation. And this process, takes anywhere from 10 to 20 years. And so to show that something is effective from this point to this point would take an incredibly long study to look at, right? And there's no way we'll ever be able to do a study of 10 to 20 years to show that it's effective. And in addition, along this pathway, as was mentioned earlier, there's all these other things going on. There are cancers, there's infection, and there are flares of inflammatory bowel disease. And then there's also impaired quality of life, and we'll be talking about that as well during this conference, the fatigue, the pruritus, abdominal pain, those sorts of things. And those are legitimate things we should target for therapy as well. So how do we get to an approved drug for PSC? And this is true for essentially any drug therapy. We have to go through a process of various phases of development. So phase 1 study looks at a small number of patients. Typically, everyone gets drug. It's open label. It's looking at basically one or a few doses given just a single time or a limited number of times. It's looking really at the pharmacokinetics. That is, how is the drug absorbed, how is it metabolized, and what is the safety? Is there any short-term safety problems with it? If it passes that, it then goes into phase 2 studies. This looks at an intermediate number of patients. It can be double-blind. That means that both the patient and the investigator are blinded to whether the patient is actually getting the drug or placebo. And it can be dose ranging. That is, there may be testing of multiple doses to try to identify what is the most effective and the safest dose of that medication. And there's usually some measure of efficacy, some idea that this drug might be effective. And for PSC, this has generally been alkaline phosphatase. We want to see a reduction in the alkaline phosphatase. And of course, the problem with that is it means that you have to have an elevated alkaline phosphatase to do the study. It also looks at safety. And then finally, if it passes phase 2, we can get into phase 3 studies, and this looks at large number of patients. It's double-blind, and it's to establish clinical efficacy and also to be safe. And if it passes a phase 3 study, that's when it can be approved, potentially approved by the FDA. This process is very expensive, and that means that there's lack of support for repurposing of old drugs or drugs that are already approved. For example, vancomycin. I know many of you probably are very enthusiastic about vancomycin, and one of the problems we have with studying vancomycin is funding for such a study, and that these sorts of studies are very expensive. There's a high rate of failure, so this is a very high bar to get drugs approved. And it's a slow process. Each one of these steps takes several years, so it can be a time-consuming process. I think it's also important to understand some of the terminology we use and that the FDA uses actually in terms of defining what is beneficial for a drug. And for the FDA, they want to see a positive, clinically meaningful effect of an intervention on how a patient feels, functions, or survives. So they don't care if your liver tests get better. That doesn't matter to them. They want to make sure you feel better. So if we have an instrument that measures your symptoms very effectively and reproducibly, and we can show that a drug makes you feel better, then it's approvable. But it also, or it has to show that you function better or that you survive longer. And those can be very difficult to show. Now, they do allow the consideration of intermediate clinical endpoints. These are clinical outcomes that can be measured earlier than an irreversible morbidity or mortality. So an irreversible morbidity was something like liver transplantation. And an intermediate endpoint should be reasonably likely to predict the medical product's effect on the irreversible morbidity or mortality or other clinical benefit. Now, to get, I'm sorry, I wish this would work. This doesn't work either. Accelerated approval for a drug, and this is how obeticholic acid got approved for primary biliary cholangitis or PBC. It's a mechanism by which a drug can get approved if it demonstrates an effect on a reasonably likely surrogate endpoint. So for PBC, reduction in the alkaline phosphatase was considered a reasonably likely surrogate endpoint, and that it's been associated very strongly with outcomes of liver transplantation or death. And that's really the pathway by which a drug would be approved for PSC as well, would be developing a reasonably likely surrogate outcome or endpoint that predicts survival or liver transplantation, essentially. So as an example, if you look at cholesterol and heart disease, there's a lot of epidemiologic evidence that suggests that high cholesterol is associated with a high risk of heart disease. There's mechanistic understanding of the deposits of cholesterol-forming plaques, and that these plaques lead to myocardial infarctions, which then lead to cardiac death, right? So pretty straightforward idea that high cholesterol is a surrogate endpoint for heart disease. And what's been shown is that with statins, if you reduce the cholesterol, you reduce the death. Now with PBC, it's been shown that patients that were treated with URSO, it reduced the alkaline phosphatase, and there's been an association with the reduction of alkaline phosphatase with URSO and death. It's not been directly proven, but it's been associated, and that's why it's been a reasonably likely surrogate endpoint for PBC. And this is just data from a large PBC study showing that if you look at the response to URSO, you reduce, and you have an inadequate response to URSO, you have an increased risk of liver transplantation or death. Now with PSC, the question is the same true? If you reduce alkaline phosphatase with a drug, is that going to reduce your risk of death? And if you look at a lot of cohorts or a lot of groups of patients, you see that alkaline phosphatase, if it responds, this is going to drive me nuts. I'm sure it's driving you nuts. Want a piece of paper? It's not working here. Here we go.
User blender feature here. Click
Okay.
right there.
Ooh. Oh. You could have told me at the start of the talk? No. All right. So these patients here did not have an alkaline phosphatase response. That is, their alkaline phosphatase did not normalize or reduce by 40% in this trial, whereas these, they did have a response. And that was a response whether they were on placebo or given URSO. So that's the interesting point. But you can see that if the alkaline phosphatase responded, they did quite better than those that did not respond. So that would suggest that alkaline phosphatase is a good measure for response to PSC since they did better. The problem is with the studies of URSO that are randomized controlled trials in PSC, we see that the alkaline phosphatase when URSO is given does improve and remains elevated if you give placebo. But the outcomes don't necessarily follow. Either there's no benefit from URSO in terms of clinical endpoints, or in the high-dose study, they actually did worse. So there's a disconnect between the response to URSO and the outcomes. And this is what's made it so difficult in PSC to develop one of these surrogate endpoints that will allow us to get drug approval. And so that's sort of, I think, my main message in terms of what our barriers are to developing drugs is how are we going to get to that point where we have a reasonably likely surrogate endpoint to get drug approval on an accelerated basis through the FDA. Now, despite that, there's clearly interest from the investigators, from the patient groups, from industry, and from the FDA, I have to say, to get this done. And no time has there ever been so much interest in this disease. And so that's, I think, the real motivating force behind wanting to make haste with what we have. So these are currently the drugs that are in the pipeline right now. There are probably others in smaller studies ongoing. But there's several studies based on bile acids. There's obeticholic acid, which is open to enrollment. NGM-282, this is a similar mechanism of action, also just starting up a phase 2 study. NOR-URSO just finished their phase 2 study and reported it at EASL, and I've got a slide for that in a minute. This drug here is meant to block the absorption of bile acids in the small intestine and prevent their recirculation. It just completed a phase 2 study, and the results have yet to be fully reported. Gilead has a very large study looking at an antifibrotic drug called simtuzumab, and that result should be out in the next, within the year. There's a new study just opening up blocking the immune cells to the liver, which is very interesting, and that's open. Vancomycin, that study at Stanford enrollment, my understanding, has been completed. We're waiting for results to be reported. And then there's, of course, some fecal microbiome transplant studies being done as well. So there's lots of different approaches being employed and lots of opportunities to participate. if you look at what the criteria for participating in these studies, they vary quite a bit. And this is both good and bad, I think, in terms of who can enroll and how we're going to study this. So most of the studies require the alkaline phosphatase to be elevated, anywhere from 2 times the upper limit of normal to 1.5 times the upper limit of normal. IBD varies. Some have a requirement that you have IBD. Some allow it, but it has to be mild. Sometimes you're allowed to have things like Remicade or other biologics. Others you can't. Gilead study required liver biopsy. Most of them at this point do not. And then whether small duct disease is allowed or not also can vary. So there's lots of different caveats here in terms of which types of patients can enroll in these studies. And depends on what the drug is and what their endpoints they're looking for are. For the most part, they don't allow patients that are at very late stages. So if you're already on a liver transplant list, you're not going to be eligible. Some, if you've had a colectomy, you're not going to be eligible. One of the big problems we have with these studies is the frequency of cholangitis in patients with PSC that happens spontaneously. And if you've had a recent episode, oftentimes you won't be allowed in a study because there's concern that you might have another episode while you're on the study. And then, of course, any evidence that there might be some early cancers or dysplasia, cholangiocarcinoma or problems. And then there's also questions about URSO use, whether you're on it or not, and being on a stable dose. So just to end with, just wanted to show you a slide from the NOR-URSO study that was reported by Michael Trauner in the European group, in which this was a phase 2 double-blind placebo-controlled trial. Patients got one of 3 doses or placebo for 12 weeks, and about 160 patients or 159 patients were randomized. 126 actually completed the study. And you can see that in terms of change of alkaline phosphatase from baseline, there was a clear improvement with each of the 3 doses all the way down to 1,500 milligrams per day, having about a 25% drop in their baseline alkaline phosphatase. So a good sign, and now this is a drug that potentially could go on to a phase 3 study, and the question we have right now is what then is going to be the endpoint? How are they going to show that this is truly effective for PSC? Showing that the alkaline phosphatase improves is not going to be enough. It's got to be more than that. So in summary, we have a lot of challenges in terms of clinical trials. There's recruitment issues, the selection criteria. Some patients may feel well and don't want to participate in trials. Many patients may not be aware of trials. These trials involve travel if you don't live near a center. This is a rare disease, and so we're limited in terms of the number of patients available for studies. There's inconvenience and cost to patients. We mentioned the endpoints problem, but there's also lots of opportunities for improving or moving forward in terms of treatments for PSC. That has mostly to do with the fact that interest in PSC is at an all-time high from all groups. And we have targets that have been identified, so there are lots of approaches, as you can see on that one slide. People are trying lots of different approaches to this disease, and these drugs are available. So I think the future of PSC, we're in the woods, but there is a path. It's still a little cloudy, but there will be, I think, soon in the near future, a clear way out of the woods into a real treatment that's effective for PSC. But thank you very much.